Fantastic. I think I'm going to kick off now. So hello, everyone. A very warm welcome to you from Oxford here in the UK. Thanks very much for joining us today for the third session of our Engaging with Evidence series. It's a true pleasure to have participants joining us today from across the world and across different sectors. My name is Tanya Hamid, and I'm a Research and Policy Associate here at the Government Outcomes Lab, based at the University of Oxford. I'm really excited to be here with you today and to be co-hosting this session with my colleague, Andrea. In today's session, we will be learning more about the Utkrisht Impact Bond, which is the world's first development impact bond focusing on maternal and newborn health. The project is based in Rajasthan in India and aims to improve the quality of delivery care in private institutions. So the objective is very much around reducing maternal and newborn mortality. More recently, Midline results from the project were published by Mathematica, who are the independent assessor for the project. We will be discussing some of these results today and also hearing from key partners for the project about their experiences on the ground. For those of you who might be joining us for the first time today, this session is part of the wider Engaging with Evidence series. We launched the series back in January and designed it as an open platform for policymakers, practitioners, and researchers around the world to engage with key findings from the latest research and evaluation work in the field. So while a lot of research and evaluation work is coming out, we are hoping that through the series, we can distill some of the key research findings, while at the same time bringing in practical insights from practitioners across different sectors, different fields, and all the while have a very honest and constructive dialogue around that. For our previous sessions, we've looked at impact bonds in Latin America, as well as emerging evidence on FCDO's pilot program for development impact bonds across Asia and Africa. You can find the recordings and slides from these sessions on our website. We do have many more sessions planned, and it might be worth marking your diaries already for the next one, which will be on the 19th of April around the use of outcomes funds. You can sign up on our website. We'll also be dropping a link for this in our chat shortly. And coming back to today's session, we have three main parts to the discussion. Firstly, we'll be kicking off with an overview of the Utkrisht Development Impact Bond. Secondly, we'll be looking at some of the key findings from the Midline report from Mathematica. And third, and finally, we'll be looking at a panel discussion around two core main themes. This will indeed be the bulk of the session. So we'll be looking at some reflections on working under the DIB collaboration model. We'll also be looking at some lessons learned from DIB implementation, particularly from COVID-19 adaptation. So this will be a really great opportunity to hear from some of the key stakeholders of the DIB, who we are very lucky to have with us today. We usually try to have a very engaged and interactive discussion, so please do keep dropping in any questions or reflections into the chat, and we will pick these up throughout the session. Please do keep your cameras on if that's possible. It's always great to see people's faces, but please do keep yourselves on mute unless we ask you to contribute. We are recording this session and we will be uploading the recording onto our website shortly after the session is completed. The slides and report for the session are already online on our website. And so to kick us off for the first part of the session, I will be handing things over to Dr. Marianne Etiebet to give us an overview of the project. Marianne is the lead and executive director for Merck for Mothers, one of the outcome funders for the project. So over to you, Marianne.
Great. Well, good morning, good afternoon, and good evening, everybody. And thank you, Tanya, for that wonderful introduction, and for the whole team at Government Outcomes Labs for this opportunity for shared learning. I'm the lead of Merck for Mothers. We are, next slide, please. We are Merck's global health initiative that was created back in 2011 to help make sure that no woman has to die while giving life. But yet today, over 800 women are still dying due to preventable complications from childbirth and pregnancy. And we created the initiative because we thought that private sector and private sector innovation could help solve for this global health crisis. We thought at Merck for Mothers that the innovation that we could bring to the table would not just be focused around product innovation, but also thinking about innovation of partnerships, innovations in model of care, and relevant for our talk today, innovation in financing. Next slide, please. One of the first things that we recognize at Merck for Mothers is that there's a huge need for more funding to help end preventable maternal deaths. If we continue along our current business as usual trajectory, global maternal mortality will not decrease nearly enough to achieve the maternal mortality targets in lower middle income countries that are outlined by the Sustainable Development Goals, which we need to reach by 2030. We need to work twice as fast and also twice as smart. As you can see, it will cost, it's going to cost, over $100 billion to help end preventable maternal deaths. But the amount of development assistance that will be available for this is just a fraction, about $10 billion. This leaves an enormous gap of investment, over $100 billion, that's we need to fill, and we need to figure out how best to fill it. There's an even bigger gap for the health-related SDGs, as you can see on the graph here. But we know that just by mobilizing 0.5% of the global capital markets would help fill that gap. When we looked at this issue, back in 2016, 2015, we recognized that the health sector really only accounted for 6% of the blended financing transactions, and only 3% later on in between 2017 and 2019. We see some progress now underway with currently 19% of transactions that are currently seeking blended capital in the health field. And we actually, hope that, part of the experimentation we've been doing with our partners around development impact bonds are partly to contribute for this renewed and increased interest in applying innovative financing mechanisms in the health sector. We are committed to being a catalyst for innovation, and we are not shy to put in some sweat equity to identify new ways to de-risk involvement for private investors that may be new to this space. Next slide, please. So why a DIB? At the time when we were discussing different options and opportunities for thinking through innovative financing mechanisms and blended financing mechanisms, our primary goal was how can we mobilize new financing, in particular financing from private capital. The second goal we had was to also encourage innovation in the implementation of the interventions to achieve the goals of reducing maternal health. And then our third consideration was whatever it is that we were going to help catalyze and experiment around, we wanted it to, in the future, be able to be an important vehicle for scale and sustainability. As I mentioned, we are a global health initiative, and many of the things that we invest in are around improving the quality of care that pregnant women receive during their pregnancy, childbirth, and after. And we recognize that we can only do so much, and that other actors also need to be incentivized to invest in quality of care. And so it was important that whatever vehicle we decided to advance also had the future potential of advancing investments and scaling investments in quality care. Next slide, please. And so in 2017, with our partners, who I will describe later, the Utkrisht Impact Bond was launched. It leverages public and private capital, as I mentioned, to incentivize innovation and specifically to improve the quality of private maternal care in Rajasthan, a state in India. While the maternal mortality rate in Rajasthan has been improving in recent years, it is still amongst the highest rates in the country, where we see about 147 maternal deaths for every 100,000 live births. And this is compared to a national rate in India of about 113 maternal deaths per 100,000 live births. Globally, we know that about 40% of maternity care is provided by the private sector, and in India as well. In Rajasthan, specifically, about 20 to 25% of institutional births are involved in the private facilities. And I want to, pause and really emphasize that with the work that Merck for Mothers wanted to do to be able to bring local private providers and local private sector to contribute to helping India and other countries around the world meet their maternal mortality goals. There was a nice synergy around using private capital, to invest, to incentivize investments in capital, to incentivize investments in quality with the local private providers, which is an area and a sector that neither government funding or development assistance had been working in or targeted. So it really was a gap in the sense of a sector that was really looking for financing and investments to improve quality. We also knew that in India, private providers are not currently regulated by national or state governments for meeting or achieving quality standards in maternity care. And there are variable quality in those private providers across the country, sometimes putting patients at risk for experiencing poor maternal health outcomes, such as maternal hemorrhage, sepsis, and other complications. So next slide, please. So we designed the Utkrisht Development Bond so that it would be able to, the investments would be able to prepare private maternity care facilities to apply for nationally available quality care accreditation to ensure women were receiving the care that they deserve. The National Accreditation Board for Hospitals and Healthcare Providers, NABH, accreditation is available to both public and private facilities, and they require facilities to meet quite extensive general quality care and facility standards. And at that time, not too many local private facilities had applied or were applying for NABH. And so by including this government-endorsed, government-run accreditation program in the DIB, we were also able to support government goals of encouraging local private providers to apply for this quality accreditation. Mathematica as well is a quality certification for private maternity care providers that has actually been catalyzed through Merck for Mothers partnerships, currently in 7 states, and it also requires that local private providers meet clinical standards. The scope of the Utkrisht Development Bond was to improve quality in about 400 facilities in Rajasthan, with an estimated impact of improving the health and lives of over 600,000 women and children. Next slide. So many of you may be asking, how does it work? It sounds complicated. Is it really a bond? And so this slide is just to give you a very brief overview of how the Utkrisht Development Impact Bond worked. What we really wanted to do is make sure that we could, as I mentioned, increase funding for development outcomes by leveraging additional private capital, as well as making sure that public and philanthropic funding could be redeployed towards programmatic investments. The Utkrisht Development Bond mechanism, which is valued at $9 million, is where the investor, and you'll see here on the slide, which is UBS Optimus Foundation, provides funding to local implementing partners or service providers via an implementation manager, in this case, Palladium, who has been responsible for tracking the performance, managing the risk, and preparing reports to facilitate decision-making. The service providers, you'll see here, PSI and HLF PPT, are working directly with the local private providers and the local facilities to support the improvement of quality of care and building capacity for adherence to those quality standards with NABH or Mathematica that I mentioned before. When the private providers, excuse me, are ready to apply to those national quality certification or accreditation programs, which, as I mentioned, is a means of ensuring their continued adherence to quality standards. The service providers inform the independent verifier Mathematica, who you will actually hear from today, because we feel that it's very important that we share, the findings and the lessons learned, of this process. The independent verifier, Mathematica, conducted field-based observations to make sure that these targets and standards had indeed been met. When they verified that, the outcome funders, Merck for Mothers, and our partner, USAID, repaid the investors, UBS Optimus Foundation, for the initial capital they provided to implementers once results were achieved and verified. And so you'll see, from this mechanism that, we were able to bring in, new money into the shared goal of improving maternal health. We de-risked kind of new investors and new financing in this space. Our ultimate goal, we were thinking, is that if we could actually demonstrate that this was a feasible model, an effective model, ultimately, we would want the government of Rajasthan in this case, or other states or other countries, to be the outcome funders. And that would be, the ultimate pathway towards sustainability and scale. Next slide, please. So just to, go a little deeper into those 3 points I made earlier about why Development Impact Bond. We mentioned the mobilization of new financing and de-risking private capital. And we also, recognize this as a way of providing incentives for the private facilities to engage in accreditation mechanisms. The other thing, we were hoping would happen is, continued kind of advancement of the different ways that public and private sector, could work together around shared goals. The second goal around encouraging innovation, you will remember from the slide previously that the focus really was on these facilities meeting quality standards and targets. We were less concerned about how they did it, because what we did want to do was encourage innovation in the implementation and focus on paying for results. And from an outcome funder perspective, our outlays were also de-risked because we went into the partnership, with a certain level of comfort that we would only be paying when these facilities actually achieved their results. And last but not least, I mentioned, this being a potential mechanism for scaling and sustaining, especially if we could demonstrate effectiveness and include government partnership in the future as outcome funders. Next slide, please. I think this is my last slide. At our midpoint, and we're a little bit after the midpoint, we've learned many valuable lessons. And some of them, I'd like to share with you right now, but really the panel speakers and that discussion and the Q&A afterwards, are a great opportunity for us to share more lessons and for you, to ask us about the things that are top of mind. We went into this, we're not a financial, organization or institution, recognizing that we needed to bring diverse expertise to the table and so also bring diverse partners and collaborators to the table. Some of the partners brought expertise in development in maternal health, in financing mechanisms, and we all had a shared vision that was very important, to align around a shared vision and bring everybody's unique expertise to the table. Our second lesson, and I think this is something that will come up in the discussion, is do the hard work to accurately define what you want your outcome measures to be at the outset. The finding and identifying the right outcome measures is hard. If you choose the wrong ones, you may be incentivizing for the wrong behavior. You also don't want your outcome measures to be too onerous and burdensome, because really, the hope is that the beauty of a DIB is to, easily be able to have shared understandings and interpretations of the targets. What we learned, during the process is that we did have to have a certain degree, of flexibility, around thinking about the outcome measures as we better understood what the capabilities and possibilities were in that environment. The next slide, sorry, and the third lesson was really, to the extent that you can, design flexible payment and financing structures. Like all of you, the DIB, has been impacted by the COVID pandemic, but we were actually really excited to see how not just the service providers, but the facilities on ground, really innovated quickly and pivoted to figuring out how to do quality improvement training remotely, figured out how to do assessments remotely, figured out how to leverage the network of these providers, to address COVID-specific issues. And so we also, had to be responsive and, think about what we needed to adjust or amend due to the pandemic. And then last but not least, the DIB is about learning. There's a robust learning agenda. Again, thank the Government Outcomes Lab for the opportunity to share some of those insights and learnings today. And I think that all of the collaborators, and you'll hear from them, we all shared, a commitment, to learning, a commitment to experimentation, a commitment, to the shared goal of improving the quality of care and reducing maternal mortality. And that really was essential for the success and continued implementation of the DIB, because there were, some bumps in the road and significant barriers and challenges and surprises along the way. But it was because we had that shared vision, as well as the commitment to learning, that allowed us, to get through those bumps in the road together. So I'll end there and hand it over to So, who led the midline evaluation by Mathematica. Thank you.
So thank you so much, Marianne. Thank you for such a helpful overview and for also talking through some of the rationales and vision for putting together the Development Impact Bond. We'll be coming to So in just a second, but before we do, I wanted to take a couple of questions from the chat, actually. We're having a lively discussion there. There's a question from Jasper, and I was wondering, Jasper, if you wanted to perhaps unmute yourself and ask the question.
Sure, Tanya, thank you. Yeah, Marianne and everybody presenting today, thank you very much. This is fascinating. And all realizing that learning is the agenda sounds great. So I'm happy to participate today. My question is more, Marianne, on the what were the main drivers for you to decide, or not just for you, but to decide on the actual scope? So 400 clinics, Rajasthan, private. Maybe there were some other considerations as well. So how did you get to the scope that was in the end the scope for the DIB?
No, great question. So I think if I can focus on three things. One, we know from the evidence that if we are to address the quality gap in maternity care, we can actually reduce maternal mortality by about 60% plus 60%. And so a known intervention, known solution for maternal mortality. I mentioned also that 40% of births are happening in local private facilities, and historically these were not targets of quality improvement measures by either government or development assistance. So a huge gap, and being a private sector partner in this space, we really thought there was some synergy there, and this could be an area that we focus our efforts. India is Merck for Mothers priority country. It actually, well, I think Nigeria has beat it out now, but it's one of the top two highest burden of maternal mortality in the world. And so Merck for Mothers felt that this has to be a space, despite its complexity, that we work in. And Rajasthan, because we had previous work there, we had relationships with the communities, with the government, and we felt that to be successful, we needed those strong and trusting relationships with multi-sector stakeholders.
Great, thank you.
Fantastic, thanks so much, both. I see we have a few more questions, but we also want to move on to the next part of the session. So we'll be returning to some of those questions in just a bit. And for now, I will be passing it on to So O'Neill, who will be taking us through the key findings from the Midline report. So is the director for the Health Philanthropy portfolio at Mathematica, will also be independent assessor for the project. So over to you.
Thanks, Tanya, and thanks for the intro. No need to say more about me. But for those of you that have not heard of Mathematica, we're a nonpartisan organization dedicated to using evidence to forward social good and well-being for everyone. And I wanted to express that we are honored to be part of the Utkrisht IB with these great partners today, and I can't wait for you all to hear from them, more of them. And of course, honored to be with you to humbly share insights and learning with our partners. So if you could go to the next slide, please. After Marianne's overview of the DIB and reasons for going with the DIB for the purposes of improving quality of private facilities in healthcare, I'm going to speak about the results from the DIB to date, and hopefully we'll answer some of those questions that you all put in the chat about what were the outcomes for payment and so on. Next slide, please. So to do this, to talk about results, I'll start by speaking about the potential type of assessments or results that can be considered under the DIB and how we might go about thinking conceptually about outcomes at various levels. And then I'll use the Utkrisht DIB to illustrate these various type of results and what we know to date or what we will know about outcomes of the DIB. And then the conversation will be opened up for panelists. And please do put your questions in the chat. I will try to respond as I speak, if possible. If not, I'll try to circle back to them later. So next slide, please. So let's first begin by looking at the various type of assessments, as I said, and outcomes that can be assessed through a DIB. Oh, yeah, go next slide. Now, when we think about outcomes, we can, in a DIB model, we usually think about it in terms of first, those that will trigger payments in a DIB. That is the outcomes which will occur, which happen or occur that will result in payments back to the investor per Marianne's initial presentation. So you see here that verification in the context of the Utkrisht DIB is making sure that facilities meet quality standards. And those were the NABH and Mathematica standards Marianne talked about. And if facilities are verified by Mathematica as reaching those standards, payments will be made to improve that they have, payments will be made to the initial investors that as proof that these facilities have improved quality. Now, the reason Mathematica is doing the verification is, as some of you are demonstrated as experts already in quality of care in private facilities and in general in India, NABH can take a while to do the accreditation process. And throughout the DIB, what we found is actually Mathematica was able to do that certification pretty quickly. And so they came in and started doing the certification along with us. But because it can take a while to get that certification from these accreditation bodies, Mathematica jumped in as an objective verifier in order to keep the timeline appropriate for the payments that needed to be made. So we came in to verify that facilities made standards, and then the idea is that they would go on and then get the certification. But really, for the purposes of the model, it was to make sure that the outcomes could be verified in a timely manner. So in this case, you can kind of see that in the DIB model, the outcomes as assessed through the verification connect the program theory of change. That is that private facilities will meet quality of standards and then achieve better quality of care and health to the financing piece, so that the payment will be made for those improved outcomes. Now, if we could go to the next slide. Okay, so go back one more. So now here, and I'll just do it here. However, it's not the verification is not the only type of program assessment that can be done. As some of you mentioned, why not use mortality or morbidity as the core outcomes? And I'll speak to that in a little bit. So, in order to make that leap from quality improvements to better, that result in better quality of care and then health for women and children, there is another type of assessment that can be conducted. That's evaluations. And the evaluation in this context would prove or disprove if the quality improvement really resulted in better health outcomes. Now, sometimes depending on the outcomes of interest, the outcome being verified can be the impact outcome. So it can be this, you can do the verification where I have this evaluation here. But often in social sector work, we know that these ultimate outcomes, such as well-being, long-term educational attainment, employment, food security, and housing stability, can take many years to actually see changes. And even then, it's hard to attribute to the extent that the program caused these outcomes. So if you have a strong evidence base already linking these more proximal outcomes to the long-term outcomes, that might be more appropriate for a DIB model, in terms of timing for payment. And then finally, another kind of assessment is learning. And the way that we distinguish this is, you may have heard the terminology of monitoring, evaluation, and learning, MEL, or MLE. Some people do it that way. So here, what we're doing is calling the monitoring piece of that verification. And all of this to say is that there's another type of program assessment that can be used for program improvement and learning, and using qualitative and quantitative methods to understand how better to execute the program. So that's the learning piece that you see right here between the program implementation of the support to the private facilities and the achievement of quality standard. So, in the case of the Utkrisht, it's the support provided to facilities and whether that support helped result in quality improvement outcomes. And that process evaluation of the entire DIB and this learning piece was done by CMS, Catalyst Management for Sciences. All right. And here I have a question. Is there an evaluation of maternal and child health impact, even if not used to trigger outcome payments? There could be, but not in this case because of the, and I will get to that in a minute, because there was an evidence base of these standards linking it to better outcomes. And then I'll talk about how we're going to look at that. So this will partially get to that question. So just to recap, verifications to make sure that agreed upon measures of success for the DIB are achieved and are usually measured at cadence, the same cadence through which payment is needed. And in the Utkrisht DIB, Mathematica was asked to play that role of a verifier. The evaluation is the assessment of impact on the ultimate outcomes. And often these types of programs assessments are used to inform decisions about whether and by how much to scale up, what to scale up, and whether funding should be put into the program and where. In the context of the Utkrisht DIB, impact was assessed by Mathematica. We will assess this by using a simulation model. Again, because this evidence base was there for the standards to see what outcomes would be achieved for maternal child health in the long run. And so as I mentioned, like the reason this rigorous traditional evaluation methods were not used has to do with decisions at the beginning by partners that there's already a sufficient level of evidence available to link the specific standards of quality to those ultimate outcomes. And finally, the purpose of program assessments geared towards learning are for purposes of ongoing program improvement and should be timed to when there are opportunities for program adjustments or recalibrations. And in the case of the Utkrisht, a process evaluation of the DIB, as I mentioned, was done by Catalyst Management Sciences, and Mathematica's verification data provides some insights into specific areas where facilities had an easier time of achieving quality standards and where they had a little bit of a harder time. So if we can go to the next slide. So keeping in mind these type of assessments, what we have seen in terms of the each type of program assessment is what I'm going to talk about now. And as what Marianne spoke about, what we see in terms of verification is that in the sampling approach of the verification, there's many more facilities than were sampled. We assessed 130 facilities. And this is out of a total of more than that. And I'd say 540. So we took a sample to verify. And luckily, my colleague Dana is on the phone if you want to hear about the sampling method, and thumbs up, thumbs down. But in any case, we show that the results across all the rounds that we have conducted assessments of facilities across 5 pools considered as ready. And what the results show is of the 2 types of quality standards, almost all of the facilities pass NABH. However, fewer met the Mathematica standards. Many of these Mathematica standards were focused on practice change or behavior change. And these type of changes often take longer to realize and are not as amenable to point in time assessments. And then there was about 60% that passed both standards. But in general, the DIB seemed to work fairly well in terms of getting these facilities up to standard. If we go to slide 10, the next one, 24 here. As I mentioned before, there was no formal assessment of impact on long-term outcomes under the DIB. However, we had data from facilities that were assessed and key outcomes that we would want to look at an evaluation. And we compared facilities that passed and didn't at the midline. And we do see slightly higher rates of adverse outcomes, such as C-sections, complications, and high-risk delivery, preterm births, and low birth weight among facilities that didn't pass. So in the sample, there were a few that didn't pass. And we see higher rates of positive outcomes, such as neonatal intensive care unit referrals. In the end, obviously we cannot draw causal linkages here, but the patterns seem to indicate slightly better performance. In terms of whether or not we considered quasi-experimental evaluation, as I mentioned, that was not a core goal of the verification piece, considering the evidence. So we did not do that. And that was beyond Mathematica's scope. If we want to go on to the next slide. So as I mentioned earlier, talking about evaluation assessments, there are challenges in defining social impact in health, which have a lot to do with the length of time it takes to observe these outcomes. In the program assessment world, we also have to talk about the difference between attribution, that is whether we can attribute an outcome to a particular intervention or program, or if we can at least talk about the contribution of the program to outcomes. Really, the bottom line is you probably want to do a rigorous evaluation, some of that quasi-experimental design, to get at that attribution piece. If there isn't strong evidence base to tell you whether or not achieving the more proximal outcome is going to ultimately result in the longer impact you're hoping for. So next slide. So what did we do in terms of the DIB in terms of learning? What we can say here, and I'm not going to talk through this complicated figure at the side, but I figured some of you here would be experts in maternal health quality improvement and would recognize this WHO model of a framework for quality of care in maternal health. So we can, and if we look at these various domains within this model of the quality framework that you see here, where the stars are kind of half filled in, we see where performance was mixed. And where they were like full stars was where facilities performed really well. And it was pretty easy for them to get standards, to meet standards. So that is not, and if we look at this in particular, not all the facilities perform very well on domains that require changes in behavior and practice, such as improvements in information or referral systems and human resources. So this indicates in the learning piece where implementers may have opportunities for further support. Now, in other quality domains where they did perform well include those related to infrastructure changes, and these areas are opportunities for scaling up. Maybe easier to get standards, to get to these standards for facilities. So that's kind of a quick overview of the various types of results and how to think about them in a DIB context and as applied to the Utkrisht DIB in particular. So now I'm going to turn it back. Hopefully I covered most everything.
Great. Thank you so much, sir, for taking us through those findings and also for picking up on the questions within the chat so efficiently. And also thanks everyone for a very lively discussion so far. I did want to pick up on a couple of questions for some quick reflections, so before we move on to the panel. I saw a couple of questions from Sylvia and from Mara. So Sylvia asks, how easy was it to measure some of these outcomes? And then Mara asks if you've considered a quasi-experimental evaluation instead. So if you have any quick reflections on that before we move on to the panel discussion.
So how easy was it to measure these quality standards? Let me take that one and tackle that. I think it was not difficult in the sense of the quality standards were already there by NABH and Mathematica. I think that the issue that we ran into was defining it consistently across all of the facilities in the context of triggering payments, because you want to have a consistent level of understanding of what the outcome is across all the facilities. Now, NABH and Mathematica are done by assessors, and the purposes are different. So the approach is slightly different. So I think that this is a long-winded way of saying this is like, the way that you measure depends on your the purposes. And what we did was we defined every single standard so that it was assessed consistently across all the facilities. So I think it was more the upfront work that was hard. It's not the measurement piece that was hard.
Great, thanks so much, sir. I'm also just conscious of time, so I'm going to pass it over to Andrea for our panel discussion.
Excellent.
Thanks so much.
Thanks, Tanya, and hi, everyone. I'm Andrea, Policy and Engagement Manager at the GoLab, and I'll be facilitating our panel discussion. As ever with the Engaging with Evidence sessions, we're keen that we complement the findings from evaluation and verification reports with a lived experience of the practitioners who are involved in different ways on the projects under discussion. So for today's panel discussions, we're incredibly grateful, and I am truly delighted to welcome to the session a really remarkable lineup of speakers representing all the key partner organizations involved in the Utkrisht Impact. So with us this afternoon, we have Ellen Smith from Palladium, the implementation managers of the Utkrisht Impact. I noticed in the chat there was a question specifically around the role that the implementation manager plays in a DIP, and Ellen, no doubt you'll come on to that in a second. We're joined by Zitze as well from the UBS Optimus Foundation, the investors on the impact bond. On the outcome funder side, we have two representatives. So we have Amy Lin from USAID and we have Pompey Sridhar from MSD for Mothers. Really looking forward to hearing from them and discussing in a bit more detail some of the questions, again, you've posted in the chat around the benefits of added value of funding programs using a DIP rather than more direct funding. And we're also really privileged to have with us the perspective of one of the providers on the Utkrisht Impact. So we have Pankuri Rai with us from the Hindustan Latex Family Planning Partnership Trust. Last but not least, we're joined by the director of the Government Outcomes Lab, Mara Voldi. We've invited her on the panel because we want her to reflect a little bit on how the lessons and the insights from the implementation of the Utkrisht Impact relate to other learnings that we've been gathering from the field. In the panel discussion, so we've got about half an hour, 40 minutes left together. We want to focus the discussion on two core elements. One is around what the collaboration element looks like in practice. Sort of increased collaboration is often cited as one of the benefits of operating under a DIP model. So we want to get into a bit more detail around what that looks like in practice and getting reflections on the perspectives from the different stakeholders involved. And we also want to spend time discussing the lessons learned from the actual implementation of the DIP and not least reflecting on what the COVID crisis has meant for the implementation and indeed the verification of outcomes in this context. So without further ado, and just before I start with the questions, please do continue to ask questions in the chat. I noticed that some of our panelists have already picked up some of your questions and answered them directly on the chat. I'll do my best to bring in as many of your questions into the discussion as we go along, but I will also ask our panelists if they can keep an eye on the chat and make sure that in their answers they refer back to the points made by the participants. So without further ado, Amy, could I come to you first? And Tanya, I think we could stop the slideshare and maybe we can just see all the different panelists. Is always just a bit nicer to see the people contributing. So Amy from USAID, representing the outcome funder perspective, we've heard from Marianne a bit earlier around some of the rationales from the perspective of Merck for Mothers. It'd be great to sort of get your own reflections around the benefits of supporting this project through a development impact bond specifically.
Thank you very much. And thank you for hosting this really fruitful discussion. And I really appreciate all of the live commentary and questions in the chat. I really also appreciated the overview that Marianne, you so nimbly walked through. I know it's a lot of partners and components to the DIP. And I think the elements you emphasized really resonate with how we at USAID also viewed the value and benefits of the Development Impact Bond. Picking up on some of those, I might just emphasize, I think, three components that really stood out to us as compelling for thinking about how to move forward with this the world's first Global Health Development Impact Bond. One is what we've been discussing and that So also spoke to in her presentation was the payment for results concept, and really making sure that we fixed those results, not the work plan, whereas sometimes traditional grant funding can fix the work plan and not as much on the results. And so by fixing to the results, we were really thinking about shifting risk to those private investors, as Marianne was pointing out, but also allowing innovation and flexibility and more nimbleness by the implementing partners so that they could respond to unexpected events like a pandemic as they occurred. I mentioned the pandemic, but there were also efficiencies and innovations that the partners were driving in advance as well, the earlier years of the Development Impact Bond. And that ability to pivot and respond and see what's working and do more of that and see what's not working and do less of that in a less structured way was really an appeal for us as well. And then finally, thinking about how do we get towards sustainability. I think the alignment of our results, the emphasis on these government certification processes with NABH and Mathematica really show that we wanted to make sure we weren't creating a siloed, separate, additional set of standards. We were really using what was there. We were trying to leverage and build into the government framework that was already existing in Rajasthan. So I think the payment for results and not paying when the results weren't achieved, which is difficult to do, but I think our partnership held together and was able to get there. Allowing the implementers to innovate and nimbly pivot as circumstances arose, and then certainly to make sure that we were in line with what could be a sustainable set of certification standards by using the NABH and Mathematica pieces that were already in place with the government. And let me pause there. I think that also addressed a couple of the questions in the chat about where we saw that innovation. And I think it really is this innovative approach to allowing the implementers to innovate on their own and as a daily practice, as well as the financial structure.
Oh, excellent. Thanks for clarifying that on the innovation point. Amy, I was going to come to you for that. Great. Ellen, could we come to you next? So Palladium's the implementation or performance manager for the Utkrisht Deep. Could I get you to perhaps explain a little bit more about what that means in practice, and then sort of, if you wouldn't mind sharing some reflections around what's different when you're performance managing a DIP rather than a sort of different type of contractual arrangement?
Yeah, sure. Thank you so much for the question. Managing the DIP has really been a balancing act between flexibility and rigidity. The targets are relatively fixed, but we have a lot of flexibility in how we achieve them. So the fixed targets, I think, have really increased the speed at which we work. So I think we've improved the quality at more facilities in 3 years than we would have under a traditional development project. These fixed targets also meant that we had to not only pivot very quickly after the pandemic hit, but we also later had to make up the lost ground from that shock and get back up to speed. On the other hand, the flexibility of achieving those targets means that we've been constantly adapting our approaches and strategies. So we have the flexibility to change the field implementation approach without needing to seek approvals. But for the more systemic strategy changes, we've engaged all the stakeholders in coming to an agreement.
Excellent, thanks for that, Ellen. So we've heard from the outcome funders and the performance managers. Perhaps we go to the investors' perspective next. So we've got Zitze from UBS Optimus Foundation with us. Zitze, it'd be really great to have your perspective first to the same point around the added value of supporting this project using a DIP mechanism. And then perhaps more specifically, if we could delve into some of the considerations around the outcomes definitions and metrics. I saw a couple of questions in the chat around that. So it'd be great to know what the process was for arriving at the outcomes metrics and the verification processes for the DIP.
Super. Thanks, Andrea. Thanks a lot. And I saw indeed the question on that, and then the question on our involvement as Optimus Foundation. So as Optimus Foundation, we're linked to a very large financial institution, UBS, and what we're really interested in and what we would like to see, of course, is to see if we can drive more of the private capital that sits within UBS towards the development sector. So a lot of our interest in DIBs from that perspective is really to try and see how we can prove out the model and really see how we can drive more private capital to development. And as Marianne rightly identified, there's a huge funding gap, and we see definitely a role for ourselves to try and drive more money to development. But first and foremost, we're really concerned with impact as a foundation, and that's where your second part of your question comes in, and that's where and so pointed that out already. The DIB has a relatively short time span of 3 years, so it was really important for us to have a variable that we could measure within that period. And there's a significant body of evidence that recognizes accreditation as an important mechanism to improve quality of care. And there as well, Marianne pointed out, back in 2013, Merck worked on a project to define quality of care standards together with FOGSI, the Federation of Obstetric and Gynecological Societies of India, to develop the Mathematica standards. And those together with the NABH standards incorporate known requirements to address these preventable causes of maternal and neonatal mortality. And we anticipated that when we designed the DIB, that these two accreditation standards, as so indicated, would take time to be actually accredited. Hence, and we involved Mathematica to make sure that we got those accreditation, the clinics up to the accreditation standards in time for this to work as a DIB model. And then just going to the last part of your question on how this worked for us as the investor so far. As we've heard, there have been some challenges during the DIB. In two instances, during the regular payment rounds, we did not get paid as an investor, and then what that means for us as an investor is that we need to put in more capital. And in both cases, there were very different causes for this. In the first instance, we failed the verification round. So the facilities didn't, a number of facilities didn't reach the standards according to according to Mathematica. So we really had to work very closely with the team, with Palladium as performance manager and the two implementing organizations to really make sure that the standards that were the high standards that were being achieved also were being reflected in positive verification. And in that instance, the teams worked very well to make up for that in the next round and successfully get to the accreditation standard. In the second instance, of course, potentially much bigger impact with COVID-19, where there was complete lockdown, clinics were closed for a while. We didn't want our teams to go into the field to be a potential virus vector. And there, because we had such a strong team, we really felt strongly about continuing the DIB, taking the risk as the investor, and in first priority, of course, ensure that all the teams were safe, that the clinics were getting information. One of the elements that came out of this was that clinics were quite confused about the lockdown and what was exactly happening, what they needed to do. So that's where the team played quite an important role as being a source of information to a lot of the clinics engaged in the program on how to react to the COVID-19 pandemic. And then, of course, taking a step from that to engage the clinics remotely, to continue the quality improvement program, and also working with a broader group of stakeholders here to start on looking at how we can move to the remote verification. And in all of this, we've been really happy and how everything has gone, and we're quite well on track right now. And at the moment, looks like we will be moving to an outperformance scenario, which taking back step to us as an investor, we're really happy with, because at the end of the day, that's really the aim of the program from the investor perspective, is to really outperform and reach as many clinics and get as many clinics up to a higher quality standard.
So that's very helpful, and thanks for such a thorough response. So just staying on the COVID point and sort of any required adjustments and thinking about the long-term implications, I saw an interesting question in the chat from Joseph Di Silvio from Volta Capital. Joe, I don't know whether you want to unmute yourself and ask your question or share any relevant reflections from your own work.
Yeah, sure. Thanks, Andrea. So just a quick question. So from our end, we're the performance manager on a couple of bonds, but one is the Cameroon Cataract Bond that focuses on cataract surgeries in Cameroon, as it sounds like in the name. That one, we're about at a similar point. We're finishing up year 3 out of a year 5 bond. So I'm wondering from a COVID angle, because right now we're assessing. Right now we're hitting our year 3 targets, but year 5 are a bit open, an open question right now, depending on COVID's kind of longer term impact. Wondering if if you anticipate COVID having an impact on your kind of end line targets, and if so, if there's any kind of contractual or target changes or anything like that you're anticipating as a result of that. Yeah,
I can take that. Thank you, Joseph. I spoke a little bit to this in the chat, but we had to pause a verification round because it was last spring, right when COVID hit. And so it did delay the results and the outcomes. And we had to push those facilities that we thought were going to be in that round of verification from spring of 2020 to fall of 2020. But we did very quickly pivot to remote modes of both the intervention itself, the technical assistance we provided to the facilities to improve quality standards, and also the accreditation bodies, which were in this case NABH and FOGSI, as well as Mathematica as the verifier, all pivoted pretty quickly to remote modes of working. And we actually had a very large verification round in the fall of 2020 and sort of made up that lost ground. So we had a pause, and of course, UBS Optimus Foundation as the investor is the one who bore the brunt of that non-payment in spring of 2020. But we did sort of catch up in fall of 2020. Does that answer your question?
Hi, this is Pompi Sridhar. I'm the India Director of MSD for Mothers. I wanted to answer this question. So in India, the private sector really came to a standstill in the beginning of the pandemic, but the government started to release these guidelines together with the practitioners on infection control and how to handle COVID itself. Now this, in all of the quality improvement programs, NABH and Manyata at the core have infection control. And therefore, with no time, we found a lot of demand for quality accreditation itself. And therefore, these facilities were improving quality and the private sector was roped in very soon with a kind of 2 to 3 months break to kind of continue to provide services. And therefore, the scheme could continue. So it was like literally the scheme delivered on the need of the hour. Thank you.
Thanks, Pompey, and thanks, Alan, for those additional comments. I'm seeing lots of questions in the chats around the intervention itself, how innovative it is and what that means in practice for the DIP. So I think it's a good time to bring Pankuri into the conversation as a representative for one of the providers on the DIP. Pankuri, could we get your reflections around what it means to be operating under the DIP model? And again, any reflections or lessons learned from dealing with COVID specifically?
Yeah. Thank you, Andrea, for the question, and good evening to everybody from India. I will take your question to highlight few of the important learnings and components of the program, which will be helpful for any partners who are considering DIB in future. Foremost, I think for any program, but especially for DIB, partners alignment lays the foundation of a successful program. One, because it's a new area, of course, but it is very important for the partners to have a common goal setting, have outcome planning matrix defined, and the expectation setting is right, because there is a lot of possibility of innovation and flexibility also in the implementation involved. So if the partners are on board and the outcome and the goals are defined, it's easier for the implementation partner to plan their implementation strategy and do the course corrections. That's one very important point. The other very important point that any service provider who's planning to implement or take part in a DIB implementation is they should not aim for any niche area for the implementation. So as somebody had also pointed out in the chat, PSI and HLF PPT, both service providers actually had past experience of working in the same geography. HLF PPT had similar experience of working in quality improvement initiatives. So how that helped us was we were able to do a baseline, we were able to define the level of effort. And why this is very, very critical, especially in a DIB kind of program, is that it minimizes the risk component. The risk component will always be there, but you have to keep planning how you can minimize that for the program. Now, for any impact bond program, prime focus is around how most effectively, efficiently you can achieve the outcomes. And two very important points for that is one, using the PMIS system not as a data input and report forming and data collection software, rather using it for data-based decision-making tools, course corrections, assessing the impact of the innovations you are trying to do in the program, what works, what does not work, and quick raising red flags where you're going wrong and improving yourself. So unlike in any other program where you use PMIS for a data entering and report making tool, here it's a decision making tool, which has helped us a lot in deciding the ready pool for the audits which were conducted for the program. The other important factor here is also the flexibility which comes in to the implementers, which is exciting. But then also we have to move in caution, because every 6 months we have our audit plan. So we have to very quickly ensure that what we are trying to bring in is actually helpful for the program. And I would like to link this point to the other question that you, the other part of the question that you had was how we were adapting ourselves during COVID. So one very good example, and I think in brief sections, everybody's kind of touched upon this point. During COVID, of course, everything went to a standstill and everything was locked down. And unfortunately, and the sad part or the difficult part was that the private hospitals were at the core of this. So they were also affected by this, but they also had to provide services. They could not shy away from the whole responsibility of this. Was actually the time when they had to perform. And as Pompey ma'am has already discussed, there were a lot of guidelines on how you can start the operations. But then imagine having 5 standards and 5 different documents saying a lot of things that you can do this, you can do that, but how do you actually do it? So this actually worked out as a good thing for our implementation during that time. So while we were doing 100% field-based capacity building for these private providers, during the lockdown, we engaged all the hospitals through a virtual mode, and all our capacity building, which was focusing on infection prevention, but also on other components, was moved to a virtual mode. And how this helped us, as the unlocking process started, we moved to a mixed methodology of capacity building. So we're now doing field-based plus virtual capacity building sessions for these hospitals. And since during lockdown, they had got acquainted and they had got used to using these virtual modes for the trainings. So they were quite open to the idea of, okay, we can use these virtual platforms for the training sessions. And I'm happy to share that even Sister had mentioned this earlier, but we are actually going to plan for reaching more than the deliverables which were committed in the program. So I hope I've answered both your questions, and if any other question you would like me to address.
You certainly have. Thanks so much, Pankuri. And please do keep those questions coming on the chat. And huge thanks to all the speakers for their amazing multitasking abilities. Thanks for picking up a lot of those questions directly in the chat. Pompey, representing MSD for Mothers, I'd love to come to you. So we've discussed some of the rationales for MSD for Mothers being involved in this initiative. Would love to know what some of the lessons have been. Has your thinking changed since the inception of the program? What are some of the key takeaways from the outcome funder perspective?
Thank you, Andrea, for the question. So first, the DIB, through its focus on results and quality, has brought quality to the forefront. So just to give you a data point, it took about 12 years for 400 hospitals in India to get NABH accredited. And in the DIB, about, in 2.5 years, we have approximately that number of hospitals doing NABH and Mathematica. And so you can see how we've been able to achieve scale. And not only that, Rajasthan now has a quality culture in the state. And there is demand for NABH, there is demand for Mathematica. And that's what the government has been trying to do. Secondly, we have also learned that development impact bonds, it's not a kind of a hands-off approach. There is continuous mentoring that is required. And what this does is somewhere indirectly or directly pushes towards sustainability of the quality culture. And that is very encouraging. And that's something that the government of India wants to really gain insights on. The other thing that I feel, the DIB created was this realization that there is dependency on the ecosystem. So when the pandemic hit, we had to work very closely with NABH and FOXI to handhold them on virtual means for certification. that kind of, I think, helped increase the collaboration and the bond that we now have with NABH and Manyata, and for those processes and systems that we have been able to put that are going to go a long way in establishing some very nimble processes. What I would have liked to see is, a little bit more transparency. As an outcome funder, I feel that we had less access to data, and we would like to see a bit more of that. Thank you.
Thank you so much. And Pompey, there were quite a few comments on the chat earlier around the sort of like long-term sustainability of this initiative and sort of like potential for government to act as the outcome funder. I know you've briefly answered on the chat, but was there anything else you'd like to add?
Yeah, you'll be happy to note that given the call for sustainability, there are UN organizations and funders who are now putting together a DIB design funding facility, where we are hoping to include and contribute the lessons from our DIB, and these can then help to kind of, come up with more DIBs and social impact bonds. The next bond that is coming up in India is going to incorporate lessons from Rajasthan. It's already underway in the design phase and has buy-in from the government and is going to work on maternal healthcare. So I feel that, we have learned a lot from the other DIBs like the education DIB, and there needs to be continuous sharing of lessons for DIBs to evolve.
Great, thanks so much, Pompey. Mara, I'm keen to come to you in a second because there were a couple of questions in the chat around the broader applicability of the lessons learned from the Utkrisht for potentially other sectors or the international development space more generally. But before I do that, I noticed a really interesting question from Tista, I think, in the chat, who was asking who actually initiated the conversation around the Utkrisht. So where did the idea come from? What was the process around that? I'm not sure who wants to take that question. Ellen, I'm guessing as the sort of organization bringing together everyone, you might have a good sense as to the answer to that question. But others jump in.
Yeah, I believe a lot of the initial impetus did come from Palladium, building on previous quality improvement and maternal health projects that we have done in India, and bringing in the relevant partners, all of whom had sort of different interests and different emphasis, and leading a co-creation process from that point on. I don't know if any of the other partners would like to add in about the design phase.
Yeah, no, I think, Ellen, you're exactly right. This really took the passion, of a couple of individuals to really drive the co-creation phase. And I think, Merck from Others, was there right at the beginning. As I mentioned earlier, we were already collaborating in Rajasthan around improving quality of care in the facilities. So I think, this was also quite a bottoms-up approach for people who were already active in that ecosystem.
And I'll just chime in as well. I think that I really like that term you used, Ellen, around co-creation. I do feel that from the beginning, it went through a few iterations in that design phase. And many of the individuals representing the organizations even today are different from the ones who had started a few years ago at that design phase. And it speaks to, I think, the real commitment that the organizations had to this model and to pioneering a new approach, that it outlasted individuals and it really stuck within the organizational support.
Lovely. Thanks so much. Mara, could we bring you into the discussion at this point? We heard lots of different perspectives. Some of the participants on the call are interested specifically in maternal health, but others might be interested more generally in the application of impact bond models to fund social programs. How do the lessons learned, the insights from the Utkrisht resonate with what we've seen in other places in the UK, internationally? And then if you could do a little bit of a distillation for us, so small ask for you, a distillation of the kind of most relevant learnings for anyone interested in designing and implementing impact bonds.
I thought it was a difficult question. I think I would give the same answer to both questions in terms of the reflection and distillation. As I read the report and as we prepare for the meeting today, and I heard all the comments that people had, there are two things that really, I think, stood out for me, maybe three, in terms of the generalizable lesson from this model to other models, also in other policy domains. And the first one is the importance to have a clear theory of change. So one of the things that was refreshing to see in the report and also the presentation that Marianne you gave, there was an intention about the use of an impact bond mechanism over and above the intention of what was happening in the program. So time was spent in trying to understand why using an impact bond instead of using direct funding or other mechanisms. And I think this is really interesting. So you emphasize the importance of mobilize different type of capital in this sector. And that leads to helpful learning and strategy on how the financing mechanism can be helpful. So I will be curious to hear from Sitze in due course, how much of the UBS clients are persuaded by this way of working and are more confident in directing resources. It's too soon to say, but the fact that this is the journey you're on is nice to see that is explicit. And attached to that, I think it's important to have a sort of clear what happens at the end of the program. It's an exit strategy. So the program is for 3 years. What happens at the end of these 3 years is about the learning for the local government, is the learning for the outcome funders for the specific facility. And I find that often people don't give due attention to articulating what are we going to do at the end. But if you have a clear theory of change of the program and of the use of the impact bond, you are in a good place to start articulating what happens at the end of these 3 years. Do you do another one? Do you do something different? Second point, one of the things that comes up all the time is the outcome is important. This is an outcome approach. And so trying to articulate and define an outcome metric that is fit for purpose is really difficult. So we heard from all the, in the report, I really invite you to read the report because there are really thoughtful recommendations of how you select a metric. And if you want to verify, how do you go at selecting an approach? The selection of the metric is key. And one of the things that I found interesting and refreshing from the conversation today that maybe is straightforward, but it was made so clear by so in our presentation, was that there is a time lag in measuring the actual impact, and setting up this structure poses a challenge in terms of the financing and the delay in which you can recover some capital and the cost that might incur. So one has to think carefully, like, yes, maybe we want to measure impact 20 years from now, but it's not feasible. So the point that's so made that I really wrote it down, like I need to write on this, I need to steal this idea, is that if you find a proxy that is a defensible like if you find a metric that is an interim metric, but is a defensible proxy for the outcome, and I'm not saying that this accreditation definitely was, but that was the attempt. So we are trying to understand, is this proxy in the short term a defensible measure to say the outcome would follow? The point that's so made was, if you have this proxy, then an impact bond mechanism is more likely to stand up because there is this timing of the longer term impact that we can't afford to wait. And I thought it was very insightful. So spend time in identifying metrics. As an academic, we always say, oh no, you need to measure the impact 10 years from now. It's very easy to say as an academic, but there is a cost of waiting, and so it has to be feasible. So I thought that was a helpful insight. But I would like to link it to some of the comments that Pompey made, because I think the proxy that we pick needs to sustain the confidence of the stakeholders involved. So is this metric measuring what matters? So are we really leading the difference that we anticipated at the beginning? And that is only generated through an open conversation among the different stakeholders. So I don't know enough about this accreditation to say this is a perfect metric, but the intention, the questions that are posed to the metric are the right questions. And the last little one that is, I agree on, at the end of the report, or also in the presentation, so said, it's important to think about the different roles that the validator of the outcome can play. So we can do the auditing role, but there is a lot of learning that we can support, and we can think about linking this metric to a long-term impact. So it's a self-plug because as a GoLab, we really believe in learning. So great to hear that learning was center stage. I'll stop here.
Great, thanks so much, Mara. And there was another more specific question around the applicability of the DIB model to other policy areas, including agriculture and lots of other areas. So perhaps I think it would be interesting to hear from Zitze what other types of projects UBS Optimus Foundation is supporting. But before we come to Zitze, just to remind everyone, Tanya has helpfully dropped in the chat the link to the global database or global impact bonds database rather. So that's a database that the GoLab hosts, which includes information on all the impact bonds launched across the world. So that includes social impact bonds and development impact bonds. And again, I've noticed there was a question in the chat around the difference between the two. And we could spend hours just debating what that difference is and how meaningful it is. But very simply, in a social impact bond, the outcome funder tends to be a government agency, whereas in a development impact bond, the outcome funding comes from a either multilateral agency or donor agency and so on. So that's what the distinction is. We just tend to refer to them as impact bonds just because we think the emphasis should be on this sort of like payment for results, payment for impact mechanism. Right. Zita, can we come to you and sort of just for some general reflections around any other areas or policy areas where DIBs are being used?
Yeah. And I'll also try to be brief. And I just posted a comment as well, just on kind of our thinking and our broader development direction, where we're developing a larger DIB fund that would invest in a number of underlying DIBs. And then to your question specifically, so we've seen this can work really well in health and in maternal newborn health specifically, and of course, in health more broadly, we've heard about the cataract bond in Cameroon. Apart from that, we currently are funding an education DIB in India, which is going really well. So that education is also an important area. Another area we've seen work really well is employment and skilling. Where, for example, in South Africa, there was a really good SIB developed for that, with interestingly also proxies that were able to be measured through PwC, so a Big Four audit. That was quite a very interesting model. Unfortunately, that DIB was cancelled due to COVID and the economic crisis there, but interesting model to look at. And of course, another one to mention is a SIB done in Colombia, where which focused also on employment and used government data, which is also very interesting because that government data was very good and deemed very good to be able to base a DIB on. And I'll just stop there because I think there's quite a few other questions which my colleagues here would be happy to answer.
Yeah, that's really, really helpful, Jis. And again, I've noticed you've picked up some of the questions in the chat, and presumably, because we're not going to get a chance to cover all the questions in the chat, presumably you're happy for participants to get in touch with you after the session if need be. And just as a reminder to everyone, the slides from today's session are already available on the GoLab website, and we will share the recording of the session as well. We've only got 4 minutes left, unfortunately. Wow, time really flies when you're having interesting discussions. So I think just a final question that I want to ask of all the panelists. I suppose often a kind of measure as to whether a project was successful or perceived as having been successful is whether people would sort of like, if given the option, would do it again. So my final question to each of the panelists from the partner organizations involved in the DIB is, with kind of what you know now, would you do another DIB? And if so, what would you, if anything, would you change anything with the kind of benefit of hindsight? Anything you wish you'd known when you embarked on the Utkrisht project? So I'll go to Amy first, then Zitze, Ellen, Pompey, and looks like we've lost Pankuri, but I've got Marianne here. Great. So Amy, over to you first. And if you can keep it to 30 seconds or 1 minute, that would be hugely appreciated.
Great. Thank you, everybody. What a rich discussion. I think We would be interested in doing another DIB, but it's not a one size fits all, as we've just discussed for the last hour and a half or so. And so the conditions would have to be right, clear metrics, clear expectations, very open communications with a committed set of partnerships that would enable that to work. I think that's really what we've found in Utkrisht and what we would look for in another one. If we were to do it again, and if those conditions were met, we would also look to see if we could make it a more streamlined contracting process. We talked about the co-creation earlier. That was not a short process. It was almost 2 years of design. And so could we accelerate that for a future one with fewer and more flexible contracts that would also make it easier to do and lower the transaction cost. And I did put this in the chat, but I do think this idea of setting expectations of what a DIB would do and what it cannot do from the very outset would be really important. This DIB was never designed to measure outcomes. And I think if we could have been maybe even clearer on that front, that would not have led to any expectations I would do otherwise. So that's my 30 seconds or
Excellent.
45.
Thanks, Amy. Did say really rapidly. Over to you.
Yeah, absolutely. We are actually developing a DIB investment fund, so we definitely would do another one. I think we've learned a lot, so we will be able to do a lot of this contracting a lot quicker. Thank you.
Thanks, Ellen.
Yeah, Palladium would do another impact bond. One thing that we would replicate is a similar governance structure among the partners. And one thing that we change is even more checkpoints and guidance for adaptive management along the way.
Excellent. So up next, I'll go to Pompey, and then I'll invite Mary-Ann so as well to share sort of final reflections. And notice Pankuri is on the line with us. So after Pompey, I'll come to you, Pankuri.
So when we started DIB, I heard that health DIBs were the most difficult. It's access to finance, education, and health. And I think we're encouraged by the success of health. And now the DIBs that are being developed in India are called Pay for Success. I would really like more government alignment and exit strategies like all financial solutions to be worked out right at the beginning. Thank you.
Great, thanks, Pompey. Pankuri, could we come to you next?
Andrea, and like all other partners have said, HLF PPT also will be very eager to take part in any other DIB program. In fact, right now we are discussing another DIB on TV because it has very clear timelines, and we have 2025 as NTB elimination timeline set by our Honorable PM. So we are currently working on developing a DIB on TV. So looking forward to that.
Excellent, great. And can I invite final reflections now from Mary-Ann and then from So?
Great, thank you, Andrea. I think just quickly, following up on Pompey's point about a culture of sustainable quality that's happening in Rajasthan, I think the price of culture change, we've all heard the saying, culture eats strategy for lunch. Is priceless, and this was the first one. The first phone was huge and clunky. We've learned from this, but it was definitely worth doing it because you can't pay enough for cultural change. Over.
Yep, and I would say that Mathematica is now been beginning to be involved with a few other DIBs. My colleague Evan Borkham's on the phone and has been leading that charge. I will say that my expertise is in maternal child health and health equity and community health, and therefore only certain conditions, as Amy was saying, are the ones that work for me for a DIB. But I would say that my big takeaway is don't underestimate the importance of measurement and flexibility at the outset. And I wish that we had facilitated more sessions with partners to really understand the measurement and what it really means at the outset.
Right, excellent. Thank you all so much. So I think, I won't even attempt to summarize all your different brilliant insights. I think I'll leave that for each of the participants to do as relevant to their work. But I think for me, three things that, stood out from all your different contributions is really this message around the clarity of purpose, or what Mara called the theory of change, and articulating that really clearly from the onset, robust outcomes, flexibility around, and co-creation around how we define, how we think about the verification mechanisms that we attach to those outcomes, and thinking about how we might track those in the long term. Learning mindset, adaptability and openness of all the key stakeholders to learn from each other and be really open and share that learning as widely as possible. And thank you all so much for doing this with us this morning. We're almost afternoon now in Oxford. Huge thanks to our audience. I'm always so impressed by the quality of the questions that we get from the participants to this session. And once again, I'm really grateful for such a rich discussion and really insightful questions. Huge thanks to the speakers for making the time to join us this afternoon. A special thanks to those in the US, Marianne, Amy, Ellen, so as well. I know it's really early for you, Marianne in particular. I know you had to worry about kids running around just before the school run. So really huge thanks to everyone for joining us. And I hope to see as many of you on the 19th of April for the session where we'll be discussing outcome funds. Thanks, everyone.
Thank you.
Thank you. Take care.